Last talk in this session from Sebastian Boland, who's going to give us an update on approaches using gene therapy to target GBA.
Thank you very much for your kind introduction. Let's see. Yeah, it's just mentioned. Thank you again. There we are. So I'll be talking about gene therapy for GBA1-associated diseases. But before I go there, I also want to thank the organizers for extending an invite to Prevail to talk about this. So this talk is considered as a high-level overview of what's going on in the gene therapy space. And if you see the slide, and I noticed this, if you see the slide of the sponsors in the breaks, you can actually see how many of the sponsors are gene therapy companies and how crowded this field is getting. And I think there's a lot of excitement around gene therapy, specifically for GBA1. This is my conflict of interest. Now, what is gene therapy and how does it really work? I have it categorized here in three subcategories: in vivo gene therapy, the ex vivo gene therapy, and gene editing. And in the in vivo gene therapy, a gene is packaged into a vector, into a capsid, and that is a healthy copy of the gene. And then you administer this to the patient to deliver the working gene into the specific cells, tissues, or organs. For the ex vivo gene therapy, you first remove the cells from the patient, and then you do a similar approach. You infect it with a vector, with a capsid, that delivers a healthy copy of your working gene into the cells, and then those modified cells are put back into the patients. And the gene editing is an approach where you use a repair system, and you have 40 elements of DNA within a gene, and they are removed, disrupted, or corrected inside the cells. And this typically uses a highly precise repair system, such as CRISPR-Cas9. The majority, or the talk actually focuses mostly on the in vivo gene therapy. And I do want to start by mentioning a couple of advantages and challenges and opportunities to gene therapy. So the advantages to me are very strong, and gene therapy is really ideal to treat monogenetic diseases. So these are diseases with a clear underlying genetic cause. Gene therapy is considered as long-lasting, so you have a one-and-done dosing. In the most of the studies, we think about it as an augmentation or enhancing therapy, but actually gene therapy can really be used to conduct knockdown studies of, for instance, in example, toxic gain-of-function alleles. You can also utilize gene therapy to do multiplexing, so you can do multiplex modalities. You can have a knockdown and an augmentation therapeutic gene transfer at the same time. You can build in control elements, and these control elements are used to achieve tissue and cell specificity. Capsid can be used with different tropisms. They have properties, broad or defined expression. So if you want to express it systemic or if you want to express it in a certain area. We had a wonderful talk by Capsida talking about the biodistribution of those things. And we consider it as non-integrating. Challenges and opportunities. So a challenge is to achieve transduction efficiency and biodistribution. Again, wonderful described before. Durability. The therapeutic transgene may be cleared from mitotic tissues, meaning that this leads to a shutdown of your therapeutic transgene. You need to be cautious with the fine-tuning of the expression of your therapeutic transgene, which is typically achieved through the dosing of the therapeutic transgene. While we can do the multiplexing, you still are limited in size of the therapy transgene, so the AAV genome only permits a 4.7 kilobase transgene. Off-target issues could be arising by the way of how the administration is conducted. Currently, we think about gene therapy as a one-and-done approach, and redosing is not possible. But that all of these challenges are also, in a way, opportunities for technological development, and it may be changing in the future. And the last point is the routes of administrations. And I want to highlight this point a little bit. So I'll start on the very right-hand side of the table, the intravenous injection, IV injection. And again, this is an injection site is the blood, and it's primarily targeting the periphery. But as we just saw, it is also considered as an injection site for targeting the CNS. And that is mostly achieved through the engineering of the capsids, as explained. And then it is a route of administration that is less invasive than the other ones. But currently, in the clinical trials, in the clinical settings at least, we have no biodistribution to the CNS. Again, those things are changing through technological advancement. Now, I do want to highlight the first three approaches, the intraparenchymal, intracerebroventricular, also ICV, or intracisterna magna, ICM. The injection site are the parenchyma or the CSF, and the goal of the biodistribution is the central nervous system. The advantage of doing this is that you have a relatively low dose, and it is very targeted because this is where you're going into the system, directly into the CNS. The first two, the IPA and the ICV, those are neurosurgical procedures. So these are actual surgeries, long procedures, and bear inherently some risks. I do want to highlight the intracisterna magna, the ICM, because this is a relatively short procedure, and a little bit of an explanation and background to this. It is a procedure, the ICM administration, that effectively and broadly delivers your therapeutic gene throughout the entire CNS. And if you look here, this procedure was described 100 years ago, 1929, in the New England Journal of Medicine, and the title is Cisternal and Suboccipital Puncture, a report of 2019 punctures. And I do want to highlight, and I know it's fairly small, but I do want to highlight the number one conclusion from this paper was, in skilled hand, this is not a dangerous procedure. So, and that was 100 years ago. Think about it. Now, in the meantime, obviously, this has developed as well. So we have MRI and MRA prior to the procedure. There is sedation and general anesthetics. It's done under CT-guided fluoroscopy. And the entire procedure really takes 10 to 20 minutes, with the injection itself even being much shorter. So the administration into the CSF targets the central nervous system and reduces the exposure of the rest of the body, and therefore limiting off-target effects. This is one of my favorite slides because it really shows what we have been talking about for the last 3 days, really, right? And the meshwork of these arrows really shows that we are still not really understanding. Is it the increase of primary substrates, such like glucosylsphingosine? Is it maybe the decrease in ceramides? Is it secondary lipids? We talked about glucosyl cholesterol, right? Or is it the lysosomal dysfunction, which is also underscored by many lysosomal genes that are changed in Parkinson's? But again, the cause and the consequences into neurodegeneration, inflammation, or protein aggregation are still trying to be understood and to de-ravel. Now, with gene therapy, we are putting back a healthy copy into the patient, and that will change or normalize the GCase activity. And hopefully, whichever way this mesh work here works, we will change the substrate, the primary substrate or the product, possibly normalize secondary lipid changes, and hopefully get normalized lysosomal dysfunction, ultimately leading in reduced neurodegeneration or slowed neurodegeneration, reduced inflammation, and reduced alpha-synuclein aggregation, which then should reverse the Parkinson's disease pathology of the brain. GBA is the one example, but it's part of a spectrum, including neuronopathic Gaucher, and they are part of this continuum. I will not go into mild, moderate, and severe mutations. I will just say that the numbers and the type can then lead to changed enzymatic activity, and that ultimately might increase disease severity. Again, on the spectrum, we have PDGBA patients, we have type 2 Gaucher patients, which may develop Parkinson's, as well as type 2 neuronopathic type 2 and 3 Gaucher disease. Now, how can we use the gene therapy for GBA1-associated neurodegeneration? So the glucosylceramidase or glucocerebrosidase, or GCase, I'll stick to GCase, is encoded by the GBA1 gene. That is then packaged into a capsid, typically in AAV. In our case, it's an AAV9 capsid, but just generally in a capsid. That is then administered to the patient through different route of administration, as we discussed, and that leads to neuronal transduction and eventually GBA1 expression. And GBA1 is a secreted protein, and for that reason, the neurons that are freshly transduced and are stably expressing GBA will also secrete the protein. And then it comes to a secondary effect where you have a cross-correction between, for instance, neuronal cells and across maybe neighboring neuronal cells or neuronal cells and other subtypes of the CNS, like microglia. So you have inherited in this approach that many companies are now using the stable expression as well as the cross-correction. I want to highlight 3 clinical stage Parkinson's disease gene therapies. The first one is MIRA GTX, the second one AskBio, and then the P01 by Prevail. The MIRA and AskBio are both using AAV2 capsids. For the AAV GAD, this is the GAD overexpression that is injected to the subthalamic nucleus, the SNT. GAD overexpression suppresses SNT hyperactivation, might restore cortical activity, and hopefully improve motor function. For the AskBio approach, this is an AAV2 GDNF to stably overexpress GDNF transgene. The GDNF gene elevation in the substantia nigra or striatum should protect dopaminergic neurons, and that could slow or reverse disease progression. And then the P01 is currently the only clinical stage gene therapy for GBA1. We're using an AAV9 that is administered via this intracisterna magna injection, and we want to overexpress GBA1 in the CNS. This possibly overcomes the underlying pathology caused by GBA1 protein deficiency or activity deficiency, potentially slowing or reversing the disease progression. The preclinical landscape, as discussed by Simon, is very crowded. And as I said, there is a number of sponsors here up there. So there is a very great interest in these therapies and using this for PDGBA. With this slide, I do want to highlight the interest, but I also want to say that there is different types and different ways of how you can improve biodistribution in CNS. One is the route of administration, the other one is the capsid or the transgene itself. So we have heard from Capsida, but there's also some other companies, and they are all using engineered AAV9 that might be able in humans to cross the blood-brain barrier and then lead to a penetration and biodistribution in the CNS. Another way of hoping to improve BioD is actually the use of, I mentioned this before, there is dual vectors that you can use. In this case, in the case of M6P therapeutics, a GBA1 and a PPTase combination. There is also ways of actually increasing the stability of the GBA1 protein. That is an approach of the human GBA1 variant 85 by Spur Therapeutics. And we have ways of, again, modulating the capsid with conjugated AAV2 or an engineered AAV10. So all of this is to say that there is different levers that you can work with to improve biodistribution and CNS exposure using these technologies. And again, gene therapy is a very active field, and there is a ton of different development, and we'll see probably more in the future. I want to close with the overview of the PROPEL, the P01 overview. So P01 by Prevail is an AAV9 viral vector delivery of the GBA1 gene. We have 2 routes of administration depending on the lead indication. So we have Parkinson's disease with at least 1 GBA mutation, and we have the neuronopathic Gaucher disease. Both of them are treated by an ICM injection. We have a peripheral manifestation of type 1 Gaucher program with a single intravenous injection. And the clinical trials that are associated with this are PROPEL, PROVIDE, and PROCEED. PD-GBA is PROPEL, type 2 Gaucher is PROVIDE, and type 1 Gaucher is PROCEED. I'm gonna highlight the PROPEL, given that we're in the PD-GBA space. So PROPEL is an open label dose-finding clinical phase 1-2 trial. We are enrolling male and female between the age 35 and 80. Importantly, the patients are single or biallelic GBA1 mutation carrier, moderate to severe Parkinson's disease in off state with stable background medication. Again, the route of administration is ICM, and then we have follow-up readouts. We have a PO1 cohort 1, N equals 8 patient numbers. Cohort 2 is 12 patients. We do safety and tolerability, key biomarkers, lipids, proteins. We have additional biomarkers, and the efficacy is tested by MDS and cognition as well as activity of daily living. So today, we are very proud and very thrilled to announce that the cohort 1 is completed, and we have begun enrolling cohort 2. So dosing has started. And with that, I want to end on this high note, and thank you for your attention.
For a few questions.
Great talk, Basti. Malu Tanzi, University of Florida. So I like the cross-correcting term of, targeting the neurons and then the secreted protein benefits the glia and the neighborhood. What are your thoughts about whether the field should also be considering either selective or conditional correction of the periphery when we know that a lot of these cells are going into the brain? And how would we achieve that? Do we want to do one versus the other, the two together to figure out whether correcting just the periphery could help the brain, or whether you have to correct both?
Yeah, it's a great question, and we have talked about it, you and me, and I am not sure I have an ultimate answer for you, but I do think it's a very, very important point to consider, yeah.
We have a question from Ellen.
Yeah, just curiosity. You've stopped enrolling the babies with type 2 Gaucher disease. Why, and what did you learn from it?
Sorry, what was that?
Why did you stop enrolling, and what did you learn from this
Yeah,
that
so-
you enrolled?
So I want to start by saying I'm the translational science lead and not the medical director of these programs, so I have to ultimately defer you to this. But I can tell you that, and you know this, it's hard. The feasibility is hard to get enough patients, and the enrollment is these babies are very sick. So I will defer you to Sarah Neuhaus, but I think ultimately it's about feasibility.
How many people got it already?
Again, I would better refer to Sarah. Thank
All
you.
right, a science question then. Do you use the chicken beta actin promoter, or is it a
I
different?
can't hear, sorry.
What promoter do you use for this?
I would say the same answer as Capsida. I can't disclose this.
Can I ask one question, I guess, then
Yeah,
before we
sure.
close? So it's interesting to see that you're going after type 1 Gaucher disease, and I guess a question for you and people in the audience is, what do we think is some of the unmet needs still that's not addressed by ERT for type 1 Gaucher disease, and are there opportunities there for therapeutic development?
Yeah, I think that, when you look at, for instance, Spur Therapeutic has an advanced program in Gaucher type 1, and ultimately we have also shown some data on the IWGDD. When you take them off from ERT, the biomarker readout remains the same or even better. So I'm not entirely sure we need the ERT after gene therapy. I think this remains to be seen.
So for you, it's more than elimination of that, but maybe not an opportunity to have like the things that are not being addressed. Potentially, it's more just a.
Yeah. Thank you.
All right. right, thanks everyone, and let's thank all the speakers again for a really great session. We'll now break for lunch and posters and meet back here at 2:15.